My topic is why I use endo-button fixation for Latarjet or Iliac bone graft in shoulder anterior instability. This is my disclosure. Why I don't use screw. Laurent Lafosse reported his experience with all arthroscopic Latarjet with 2 screws in 2007, Pascal Boileau with only 1 screw in 2010, but they have a lot of complications with the screw, pull out, breakage, subscapularis lesion, fracture of the coracoid process, avulsion of the graft, too long screw, and they revise 6 to 10% of the patient. So sometimes the screws are too broad, too long, too oblique, too high. Without guide, the coracoid process is too lateral or too medial. So there is sometimes a compression of the nerve, suprascapular nerve, or in the coracoid glenoid notch or in the spinoglenoid notch. Laurent Lafosse reported the experience in 2014, about 62 patients with full arthroscopic Latarjet, and he reported the 10 patients coming back to the operating room to remove the screw, 1 for arthritis, 1 for displaced coracoid graft. So it's too many complications after Latarjet. It's the reason why Pascal Boileau was the first to report 1 cortical button with a small bone block in 2014. And I reported the same technique, but with 2 cortical buttons on a big coracoid bone block. And I use the same techniques at Latarjet, but by arthroscopy with 2 endo-buttons. So if we compare the biomechanical aspect of the cortical button on the screw, there is the same ultimate load to failure, and there is low fracture of the graft with cortical button. So if we compare more compressive stresses with the screw or plate, I may be responsible of more osteolysis of the graft caused by a decreasing blood flow. So we decided to use in 2013 the cortical button fixation with a glenoid specific guide, coracoid specific guide to optimize the positioning of the coracoid process. If we analyze the cortical button system, there is no risk of bone fracture. We didn't remove any button, and this is a self-locking device. We don't use any knots. We use 2 cortical buttons, more stable than 1 less rotation, if you are thus 2 centimeters of the coracoid process. And I don't use any medial portal, sutured portal, useful for screw to be parallel to the glenoid joint. So it's very interesting that to understand that the endo-button is a guide automatically when you pull the strands to put the coracoid process in front of the glenoid rim. This is a small video of the system with a guy with 2 endo-buttons. This is the axillary nerve, the musculocutaneous nerve, the subscapularis. The first step is to prepare the anterior glenoid rim and should be flat because it's very important to have a good matching between the inferior process of the coracoid and the glenoid rim. And after with a flat burr, we prepare the inferior part of the coracoid process. And it's the time the most difficult by arthroscopy. So we do a split of the subscapularis. We use a spreader, and with a posterior glenoid guide, we do 2 holes with a drill 2.9 from posterior to anterior. With the same distance, but the specific coracoid guide, we do 2 holes with a drill 2.9. After, with a system of shuttle relay from posterior to anterior, through the holes, we pull the 2 strands, the 2 endo-buttons, with the fixation of the button over the top of the coracoid process. And after we tight, and before to cut the coracoid process with a saw, to avoid any spur, we pull the coracoid process for the split of the subscapularis, and we tight the two on the button. So this is publications to show that the rate of bone healing with on the button is between 88% to 100%. There is no hardware, there is no neurological complication, and the healing bone progress between 3 to 9 months. You see that there is no recurrent dislocations, there is no revision surgery with this system between 2 to 5%. So the difficulty of the full arthroscopic Latarjet is to match the anterior glenoid rim on the inferior coracoid process to obtain a good healing and no resorption. So if I use a small bone block on one button, I do a full arthroscopic Latarjet. If I have to use a big bone block with two buttons, I pull outside the skin, the coracoid process, and I prepare outside the skin to obtain a perfect flat of the inferior part of the coracoid process and use two on the button. So the last 15 cases with the technique of preparation of the glenoid, so of the glenoid of the coracoid process outside the skin, we obtain 100% of healing, no infection, no nerve palsy, no recurrent dislocation. This is a very nice example of coracoid process. So sometimes I use two buttons because the glenoid bone erosion is more than 10%. There is an engaging lesion. Sometimes I use only one button because the erosion is less than 10%. Sometimes this is adolescent or young athlete after 10 dislocation with a contact spore, and I reinforce the bone cart with a Latarjet one button on small bone graft. This is an example of perfect integration of the bone in the anterior rim. Now, what we do now? Now, systematically, I do a CT scan and 3D reconstruction to evaluate the bony lesion and to evaluate the heel sacs. And it is important to evaluate the concept of off-track versus on-track of etoy for the indication. And I do a preoperative planification to evaluate the size, the width, the length of the coracoid process, on what size we have to use, and we do systematically a preoperative planification of the coracoid process now. If I have to use a iliac creased bone graft, indications are rare for me. This is a deep medial heel sacs lesion. The glenoid lesion is more than 25%, and after a failure of Latarjet. There are many advantages to use two cortical buttons by arthroscopy for iliac bone graft fixation. We use the bone graft and we pass the bone graft through the rotator interval. We don't do any split of the subscapularis. There is less risk to the axillary nerve. We can do a bone cart repair. Sometimes it's very difficult to remove the screw, and we use a small place to put the bone graft, and you have a good fixation even for the holes of the previous screw. This is a CT with a 3D reconstruction of perfect integration of the bone. So this is an example of a failure of Latarjet. You see the two screw, we see the bone graft, and you put an iliac crease bone graft with a 2 on button. You have an excellent results. So my conclusion regarding on the button fixation on bone graft for anterior stability, we have less complications as the screw. Depends on the indication on the size of the bone graft. I can use one button or two buttons. I don't use medial approach, and there is less risk for axillary or musculocutaneous nerve. We have the same rate of bone consolidation if we compare with the screw, 85%. And we did any, we remove any hardware removal. So thank you for your attention and muchas gracias.